Good afternoon. I would like to present my paper on treatment response of focal laser photocoagulation in onset involving diabetic macular edema. Diabetic macular edema is the common cause of vision loss in diabetics. It can be of two types, center involving and non-center involving diabetic macular edema. Non-center involving diabetic macular edema can be defined as increase in thickness of non-central macular subfields over normal threshold values in at least two of the 8 ETDRS quadrants, sparing the central subfield or at least one non-central macular subfield with OCT thickness of more than 15 micrometer above a threshold value. If left untreated, the progression of conversion of non-central to center involving macular edema is 14% at 1 year and 26% at 2 years. Only a few studies have studied the effect of focal laser in non-center involving diabetic macular edema alone, with all reporting reduction in macular thickness and stabilization of visual acuity. In this retrospective study, we evaluated the changes in macular thickness and volume parameters of OCT in patients with NCI-DME, those who underwent focal laser over a period of 6 months. Aim of this study is to determine the treatment response of focal laser photocoagulation in non-center involving diabetic macular edema. This was a hospital-based observational retrospective study. It was conducted at Retnet Clinic of a tertiary eye care hospital. Data of 70 eyes were collected over 24 months from January 2022 to December 2023. Inclusion criteria were patients diagnosed with NCI-DME who underwent focal laser with 6 months follow-up, and NCI-DME patients on SD-OCT with less than 320 microns of central subfield thickness and more than 320 microns in one of the 4 inner or outer subfields. Patients with DME of more than 320 microns involving the central subfield, vitreomacular interface diseases, other macular retinal pathologies, and patients with DME who were previously treated with anti-VEGF injections were excluded from this study. Data of basic demographics, duration and treatment history of diabetes, best corrected visual acuity and optical coherence tomography imaging were collected. BCVA and OCT imaging were done at baseline and repeated at 3rd and 6th month follow-up visits. Average inner and outer zone thickness of with diameters of 3000 and 6000 microns were obtained by averaging 4 inner and outer quadrants respectively, and changes were compared from baseline to 6 months. The Wilcoxon statistical test was used to compare the differences within the group, and p-value of less than 0.05 was considered as statistically significant. Coming to the results, 70 years of 64 patients were included in the study. Mean age of patients were 60 years and mean duration of diabetes were 15 years. 72% of patients had more than 10 years duration of diabetes. 93% of eyes showed good resolution of inner and outer zones thickness in OCT at 6th month follow-up visit. 14% eyes needed repeat laser, and 7% did not respond to focal laser and needed intravitreal anti-VEGF injections. Coming to duration of diabetes, 72% showed more than 10 years duration and 28% showed less than 10 years duration. 64% were using OHA and 36% were using insulin. Coming to the OCT parameters, mean central subfield thickness were almost similar in each visits. P-values not found to be significant. Means inner zone thickness as well as outer zone thickness showed a significant reduction from baseline to 6 months. P-value of 0.003 and p-value of less than 0.001 was noted, and it was found to be significant. So the graphical representation. And OCT and fundus photo of non-center involving DME following focal laser showed good resolution of edema. Some other case examples showing good resolution of NCI-DME following focal laser. Macular thickness map also showed a good reduction of edema. Coming to discussion, according to the current ETDRS guideline, focal or grid laser remained the first recommended treatment for NCI-DME. In our study, among 70 eyes with NCI-DME who underwent focal laser showed a significant reduction in inner zone as well as outer zone thickness at 6 month follow-up visit. Focal laser was found to be effective in 65 eyes with NCI-DME. A study by Scott et al. Found that at 1 year after the focal or grid laser treatment, mean visual acuity remained unchanged, while mean central subfoveal thickness reduced by 10 microns. They found the beneficial effect of reducing this retinal thickening in inner zone and outer zone also in volume measurements. A study by Parente et al. Reported that focal laser treatment applied directly to angiographically leaking microaneurysm has a benefit of stabilizing the visual acuity and reducing the retinal thickening at 12 months compared to observation alone. The untreated eyes in the study had a significant increase in inner zone thickness. RESTORE trial concluded that macular laser treatment was as effective as anti-VEGF injections in patients with retinal thickness of less than 300 microns. Patients with focal parafoveal edema benefit from macular laser photocoagulation in terms of anatomical and visual outcome. Pradhana D et al. Reported that 72 patients with NCI-DME without any treatments, 26% progressed to center-involving DME by 2 years. A duration of diabetes more than 10 years was one major risk factor for conversion to center-involving DME. In our study, a majority of patients had more than 10 years duration of diabetes, and focal laser helped to prevent conversion to center-involving DME in 93% of patients. AIO's Diabetic Retinopathy Task Force and VRSI recommends observation for naive NCI-DME with good vision with monthly follow-up and focal laser for NCI-DME with BCVF less than 6.9 attributed to macular edema. In our study, we have calculated the changes in BCVA from baseline to 6 months, showed no statistically significant changes. Patients with BCVA of 6.6 also underwent focal laser, showed good resolution of NCI-DME with maintenance of vision. Smart India study by Rajiv Raman et al. Found the estimated national prevalence of vision-threatening diabetic retinopathy is 4%. In a population-based study in South India, the prevalence of NCI-DME was almost 3 times than that of center-involving DME. A low and middle-income country like India should be on the watch to detect and treat the sight-threatening NCI-DME before the vision is affected and before the need for more expensive treatment arises. However, there is a lacuna in Indian literature pertaining to real-world evidence in the subset of eyes with DME, and our study addresses this gap. Limitations: a lack of a control group to determine the conversion of center-involving DME, short duration of follow-up, and retrospective nature of the study. We concluded that focal laser is both an efficient and cost-effective treatment option for non-center-involving diabetic macular edema. Majority of patients had good resolution of edema in inner and outer zones of OCT. We recommended that in eyes with non-center-involving diabetic macular edema and a longer duration of diabetes, focal laser is to be strongly considered as a viable and effective treatment option. These are my references. Thank you.
I have one question. So, was your study, or the numbers of people who have been recruited for the study was good enough? The number was good enough for the power for what you intend to do?
No.
What that could also be a limitation which you can add in your paper, right? So, what are the limitations you have in this patient? In your study, actually.
This was a retrospective study.
Apart from what you just mentioned.
We can include, if we are conducting as a prospective study, we can take more duration of diabetes for to check for conversion to center-involving DME. That means we have taken only 6 months duration. So if we are looking for maybe a 5 or 10 years duration, and check into the conversion of center-involving DME, and we can find the effectiveness of laser.
Okay.
And
okay, thank you.
Thank you.
So, after finishing the first paper, the next paper would be presented by Uni. So, Uni is going to talk on a comparative analysis of RP morphological choroidal vascular anomalies in acute and chronic CSCR.
Okay, good afternoon. So, as you said, we're talking about CSR and comparing the different changes in acute and chronic CSR. So, this is a common image which is very easy to look at. You see the spot leak, the leak, the SRF and the fibrin, and you know that this is CSR. There's nothing confusing about that. Let's start with the differentiation between acute and chronic CSR. The time period arbitrarily or in literature is 4 months. But now we know that there are two mechanisms beyond it, that is a pachychoroid and the venous overload. So the venous overload is when there's a vortex vein compression and all the vessels attributing to the posterior pole are thickened. And that translates into a thickened choroid over here, which we're just going to mark off. So what does that happen? So what it means is that because of this venous overload, there's an increased hydrostatic pressure, a back pressure, which causes all these RP changes to elevate and therefore subsequently what we call blowouts or leaks. But over time, something else happens. There is chronic damage to the inner choroid, thinning of the inner choroid, thinning of the choriocapillaris, which produces signs like the DLS or the double layer sign, where there's a small separation between the Brooks membrane and the RP. And there it causes RP damage. So basically, CSR is not about point leaks. It's about a larger area of choroidal damage with a smaller areas of RP damage with overlying leaks. So the aim of the study is to define what do you mean by a causative RP lesion. Look at the choroidal lesion right under it and see if there's any correlation. It was a retrospective where we took 30 eyes in each of the groups in which we could possibly do a good EDI study. A quantitative and a correlative analysis was done. In the quantitative analysis, we looked at thickness underneath the fovea and underneath the lesion. We checked the choriocapillary thickness, the large vessel diameters and areas, and also something called the Haller fraction. What was the fraction of the total choroid that was occupied by the large choroidal vessels? So this is how we looked at the choroidal thickness underneath the fovea and underneath the lesion. Again, when you had to look at the choriocapillary thickness, this is how it was measured under the fovea and under the lesion. The type of RP lesions were divided into three, that is single or multiple PEDs, a PED with or without a DLS, or a DLS without a PED. And the choroidal changes were looked at single large vertical lesions, horizontal lesions, and multiseptate lesions. So this would be a summary of that, where you could see this would be a single PED, multiple PEDs, a DLS, a vertical choroidal lesion occupying more than 80% of the lesion, horizontal lesions, and multiseptate lesions. Coming to the results, the age in both the categories was same. The males, as we expect, predominated in both the arms. But this is what it starts getting interesting when you look at, this is known facts. In acute CSR, the choroidal thickness and the choriocapillary thickness is more in acute CSR than in chronic CSR, which means thinning happens over time. The large choroidal vessels are thicker in acute CSR. The area of the vessels are more in acute CSR. But what is interesting, what we call the Haller fraction is similar. What does it mean? The Haller fraction is the area occupied by the large vessel versus the total choroidal area. The Haller fraction is maintained, which means that when the choroidal vessel or the choroidal vessel, when it becomes thinner, it's usually associated with the thinning of the choroidal stroma also. So the total choroidal thickness also comes down. So that has an indication, or possibly an indication about the back pressure effect that is caused by the things. Looking at the qualitative analysis, the most common in acute CSR was the presence of a single PED. In chronic CSR, the presence of multiple PEDs was the most common feature. The choroidal change, the most common choroidal change was a large focal choroidal vessel or a Pachy vessel when you had a focal RP lesion. And again, in multiple, yeah. So basically, the most common was a multiple PEDs in chronic CSR and a focal choroidal enlargement or a Pachy vessel in acute CSR. So this is how the correlation went. Whenever there was acute CSR, the most common lesion would be a single PED or a focal PED and associated with a single vascular event underneath it. While when you had a larger area of RP damage, like a double layer sign or multiple events, you had a larger, more horizontal choroidal vascular change underneath it. So just to represent that graphically, this would be a single PED with a large change. When the PEDs become multiple, you had a longer change, and you had larger and longer changes when a larger area of the RP was involved. So these are some examples. You see a double layer sign, and this would be the area of the choroidal damage. You see a single more larger PED, and the focal choroidal or vertical choroidal damage is more evident here. Here you see a larger involvement of the RP, and you see a large septate, a multiseptate choroidal anomaly. Again, a multiple PED here, and you see a larger choroidal abnormality over here. Here you see a single PED happening there with a single larger lesion and a more broader lesion whenever the choroidal or the RP damage is over a larger area. So all the choroidal indices were thicker in acute than chronic except the Haller fraction, which showed that both the vasculature and the stroma decreased over time. So a quick summary would be the choroids are thicker in all aspects in acute CSC. The acute CSC had a greater occurrence of a single PED and a contributory focal lesion right underneath it. Single PEDs were associated with larger vertical areas. Chronic CSCs were associated with multiple PEDs. And whenever you had a larger RP damage, the underlying choroidal damage was shorter, broader, and occupied a larger area. And those two are new facts basically. So we're just going to repeat that. Single PED, focal choroidal lesions. And why is it important? The back pressure effect because of the vortex veins could be responsible. The back pressure effect causing a single blowout in a single area with a single choroidal and RP damage. While in chronic CSR, a larger area is involved, so it is not a back pressure effect. It could be a more expansive deficit of the RP because of choriocapillary thinning. And that could be responsible for the chronic CSR or SRF changes. So when you want to describe the disease, when you have a venous overload or a block, you have pachychoroid. You have first focal lesions causing focal CSR, focal leakage points. But as the disease gets more widespread, more choroidal damage, more RPE damage, you have more decompensation and more diffuse RPE damage. And that is what this study has brought out. So there are different pathogenic mechanisms due to different thicknesses, different nature of the choroidal vessels, and probably a progression from an acute to a chronic because of lack of release of the pachychoroid disease underneath. So understanding this may help us understand the future of anticipating these changes and treatment of the disease. Thank you.
Thanks, Soni. I have a question. When you're talking about central serous, I could understand both the spectrums what you painted. Now, I'm just going to throw something different at you, and if it's going to be acute central serous, it's the fluid is coming from the choroid circulation into the subretinal space because of the micro leak which happens because of increase in hydrostatic pressure. When this is not evident in chronic central serous because of its chronic pressure gradient which is being built up, but not enough for the fluid to come into the subretinal space, do you think that it is an over exaggeration or the subretinal fluid, or if I have to use the appropriate words, is the subretinal fluid which is staying for a longer bit of time in its space before it finds its way into the chorea capillaris, is a possible hypothesis?
So there is one overlying hypothesis which is being floated now. In acute CSR, there is one anastomosis in the vortex veins between a superior and inferior vortex. That is the whole back pressure. And when the acute spontaneously resolves, somehow this anastomosis gets relieved. In chronic CSR, the anastomosis between two vortex veins remain, but it is not high enough. That is why it doesn't get relieved. It remains in a very background stage, and there is a chronic. So when there is SRF, there is always evidence of a historical leak. Like you said, the fluid might have come inside, but the fluid being resorbed or the RP not being strong enough to reverse the flow of the SRF, or the RP still contributing to a low level of exudation because of reversal polarity. So the second theory is associated with a lack of glue between the RP and the Brooks. The lack of stickiness that happens because of chronic inner chorioacapillary disease. And that is why as a disease gets older, these smaller separations happen rather than acute pop-up of things. And in this entire area where the RP or the choriocapillaris is damaged, there is no reversal of flow immediately. The whole dynamics of the SRF absorption decreases. So, but you cannot just have fluid. You would rather have intraretinal fluid if you have an RP decompensation, not SRF. So SRF has always historically, or at that time, there has to be some area of leak that happened. May not be as explosive or associated with an RP rip as before, but some leak should have happened. Thank you.
It would be presented by Dr. Kiran Chandran, and Dr. Chandran will be speaking on correlating gas and body staging and SD-OCT characteristic to devise a new MACTIL classification.
Good afternoon. My talk is on correlating gas and body staging and SD-OCT.
Even before you present, may I ask you what made you think in this direction?
So
was it prospective or retrospective?
It was an observational study using our MACTIL data, which we have in multiple centers actually. So a lot of data has been done using OCT as diagnostic modality in MACTIL, but so far clinical classification has not come about using OCT. Although we had a clinical staging by gas and body, but a multimodal imaging classification has not come about. So that is the interest in devising such a classification and validating the study.
Okay.
So the initial staging by gas and body was done clinically, in which the first stage was characterized by leaking cholangiomas on fundus fluorescein angiography. The second stage was characterized by parafoil loss of retinal transparency. The third stage by right triangle vessels. The fourth stage was characterized by pigmentation, and the fifth stage by neovascularization. So as I told, the OCT has been used very frequently in diagnosing MACTIL, but so far staging classification using multimodal imaging, specifically OCT, has not come about. Emily Chu and colleagues from the MACTIL group devised this OCT classification system, and 7 grades were devised in this system. Starting with, and they use a target measure of best corrected visual acuity. So the grade 0 was characterized by no abnormalities, grade 1 by non-central EZ loss, grade 2 by central EZ loss, grade 3 non-central pigment, grade 4 OCT hyperreflectivity, grade 5 central pigment, grade 6 X-rated neovascularization. And as a grade of the disease progress, the visual acuity also dropped. So ours was a multi-centric observational study involving 3 centers in India. So mackerel eyes were recruited, initially staged according to the gas and bloody staging and further corroborated using complete multimodal imaging. Inclusion criteria were conformed mackerel eyes across the different stages with gradable images. Best corrected visual acuity was calculated in ETDRS visual acuity charting with a visual acuity score of 0 to 100. Mackerel clinical staging was done as per gas and bloody, and SD-OCT features were studied. So the first one was EZ loss. As you can see in this figure, it was the disruption of the second hyperreflective band involving the outer retina. Then it's the outer retinal reflectivity, which was linear or over fusiform hyperreflective lesions in the outer or subretina, which was as bright as a retinal pigment epithelium. Then was a retinal pigment epithelial clumping and migration, which were hyperreflective clumps in the middle or superficial retinal layers extending from the RP with backscattering. And X-rated neovascularization, where clinically there was presence of lipids and hemorrhages, and on OCT, interretinal fluid or subretinal fluid with inner retinal thickening, as with outer retinal hyperreflectivity plus or minus RP clumping and migration. So more of these, any of these features can appear together. Hence, the various permutations and combinations were used to evaluate the best correlation with visual acuity decline. So the mean visual acuity change for each mackerel category for both gas and bloody and OCT mackerel grading was used. Classification regression trees, that is predictive algorithm using machine learning, was used. It is a decision tree where each fork is split into a predictive variable and each node predicts the target variable at the end. So nodes are split into further subnodes until a terminal node, that is maximum branching, was possible in that particular tree. The data was split into 2 sets, that is training set where right eyes were used to construct a decision tree, and validation set where the left eyes were used to determine appropriate tree size. So the factors that impacted visual acuity were placed into order with other factors based on progression from good to poor visual acuity at baseline for both the right and left eyes. Results: 1,432 mackerel eyes of 733 participants were recruited. Majority of females. Right eyes were recruited more than left eyes, and mean age was 52 to 68 years old. So in both the training and validation set, as per the gas and bloody staging, majority of eyes were in stage 2, followed by stages 4, 3 and 5. So this was the OCT grading which we got after comparing the data. Our staging closely mirrored that of the Western population, in which grade 0 was no EZ loss, grade 1 non-central EZ loss, grade 2 by central EZ loss, grade 3 non-central pigmentation, grade 4 by outer retinal hyperreflectivity, grade 5 by central pigmentation, and grade 6 by X-rated neovascularization. And again over here, the visual acuity declined as a grade of mackerel progress, but the only difference was that we had, in our cohort, the visual acuity is slightly better compared to that of the Western population. So this is a CART algorithm which shows that pigmentation is taken as a common attribute, and we split the pigmentation into eyes with central pigmentation and non-central pigmentation, and eyes with no pigmentation. So eyes with pigmentation had reduced visual acuity, and the grading of mackerel was in the higher grades. And as you can see in the right hand side, the eyes with no pigmentation had got better preserved visual acuity with grading between 2 predominantly. So this is an example of a 10-year follow-up showing mackerel progression on OCT using multimodal imaging using with fundus autofluorescence also. Initially, there are no changes, BCVA 6/6. Over a 2-year follow-up, again the BCVA 6/6, but there is appearance of IDZ loss, just sparing the fovea. Over a 5-year follow-up, the vision is still preserved because the EZ loss is just sparing the fovea, mainly non-central with non-central pigmentation. But once the EZ loss progresses to the center, and when the pigmentation again involves a foveal center, the visual acuity drops. So this is a figure using multiple imaging modalities with color fundus photo, blue reflectance, fundus autofluorescence, and SD-OCT. And it was done stepwise according to gas and bloody staging, and we compared the gas and bloody staging to the devised OCT classification. And as you can see, the grade 1 where vision is 6/6, there is only non-central EZ loss. Central EZ loss is happening when the vision is reducing to 6/9, with non-central pigmentation where the vision is again dropping to 6/15. Then there is outer retinal hyperreflectivity followed by central pigmentation and features of accelerated neovascularization where the vision drops to 6/60 in the validation set eyes. So vision acuity decline was not well represented in the gas and bloody classification, and vision acuity decline relates more to OCT features rather than that seen on clinical fundus photo as devised by gas and bloody. So MACTIL OCT classification in Indian cohort had similar findings as the established classification in the Western cohort, and it showed correlation of OCT findings with progressive visual acuity decline. So OCT being the single most informative imaging modality in MACTIL, therefore a grading system using OCT was needed to determine the grade as well as rate of progression and prognosis. And our findings correlate with that of Western cohort, signifying the important grading severity to assess the risk of progression and vision loss. Thank you.
I just have one more question to ask you, Dr. Chandran, in terms of, you said that the visual acuity correlated very well
Yes, sir.
with the OCT changes.
OCT findings. Yes,
right?
sir. Yes,
And this was also very similar to the Western data. which is
Western
there.
data. Yes, sir.
Now, and these you had data recruited from 3 centers.
3 centers, right, sir.
Right.
Yeah.
So, what is your new MACTIL classification? Because your paper said that you want to devise a new MACTIL classification.
Yeah.
So
The new
can you show me, because I could not, maybe I overlooked, I could not see a new MACTIL classification.
So the classification was a refined classification to the already published data, but then we were able to follow up patients in the Indian cohort, and the visual acuity
No, I
was,
just want to have a visual appeal of a new classification which you made.
yes, sir.
Can I have a look at it?
We had slightly varying data to the outer retinal hyperreflectivity, which was a grade 4 in our classification actually. And also the vision in our population was slightly better preserved compared to the Western data in the initial stages. So our data actually corroborated more or less to the Western data, but in a more refined way in the Indian population.
Now, my intent of asking you this question was, if I have to just
Yes, sir.
take this into my practice,
Yes, sir.
right? So, how do I see a class? With this, it's so hard for me to fathom a classification.
Yeah, yes. So this is the simplified classification, the table, which shows the 7 grades.
I think these are your results,
Yeah, results, sir.
right? Classification.
Yeah. Classification is using multimodal imaging, specifically OCT, where we use the permutation and combination of OCT features to see which one of them correlates best to visual acuity decline from good to poor. So the parameters we analyze for, as I said, EZ loss and outer retinal hyperreflectivity, pigmentation, and neovascular, accelerated neovascularization. And since EZ loss has been used as the surrogate marker for assessing the visual acuity decline in MACTIL, we focused on EZ loss, both central and non-central, followed by pigmentation also, because that again contributes to photoreceptor loss and atrophy. So our grading system basically focused on these 4 parameters, and related it to the target visual acuity to compare the grading system.
Right. Thank you.
Thank you.
The penultimate presentation, Dr. Chandana Prabhakar would be presenting on Lumi indent, an economical and handy scleral indenter cum retinal transilluminator.
So, good afternoon, everyone. I am here to present my paper, Lumi Indent, an economical and handy scleral indenter cum retinal transilluminator. These are my co-authors. So we know in a vitreoretinal surgery, we need to handle multiple instruments by the vitreoretinal surgeon and the assistant. Usually the endo-illuminator and the occlutum will be handled by the vitreoretinal surgeon, and the assistant will be performing the procedure of scleral depression, that is scleral indentation. So there are chances that there will be incidents of miscommunication which lead to slippage, and there can be chances of accidental retinotomies happening in the vitreoretinal surgeries. So we have identified a problem that we need multiple instruments and multiple hands to handle that thing. So there are chances of complication leading to accidental retinotomies due to miscommunication. So we need a simple frugal tool to advocate this problem. So we have found out a solution by combining the scleral depressor and endo-illuminator into a single instrument. So the surgeon can perform scleral indentation and transillumination by a single instrument. So we have made an instrument called the Lumi Indent, which will perform scleral indentation and transillumination in a combined way. So it's made by three things: endo-illuminator, a hypodermic needle cap, and a micropore. The endo-illuminator is placed inside the hypodermic needle cap and is secured in place with the help of a micropore. So this is how we have done it in the OT. The endo-illuminator is being placed into the sterile hypodermic needle cap, and it is secured in place with the help of a micropore, and this can be used as a combined scleral intender and retinal scleral transilluminator. So the surgeon can single-handedly manage the scleral indentation and transillumination. So this is how the retina is visualized during the vitreoretinal surgery by using Lumi Indent. You can see the scleral indentation and the transillumination. So while using Lumi Indent in the OT, we have observed that myopic retinas are easily visible using Lumi Indent compared to other cases. So pondering on what could be the reason for that, we have thought that the scleral thickness could be a reason for that. So we have proposed a study that aimed at establishing the relationship between scleral thickness and scleral transillumination. For that thing, we have proposed a prospective study, a questionnaire-based study. It was done in a retina department of the tertiary eye care hospital. Sample size were taken as 200, and the study period was between November 2023 and August 2024. And we have for all the patients who underwent the vitreoretinal surgery, we will take the scleral thickness prior to the surgery by using OCT. The scleral thickness was measured in all the four quadrants: superior, inferior, nasal, and temporal. And the normal scleral thickness was kept standard as 0.5 plus or minus 0.11, 6 mm from the limbal border. And the vitreoretinal surgeon will use Lumi Indent while performing the vitreoretinal surgery, and post-surgery this questionnaire will be answered by the VR surgeon. The scleral thickness will be already entered in the data, and the vitreoretinal surgeon has to enter the score according to the visibility he had in the OT. So the scoring system was that score 1 was given to peripheral retina clearly visible, 2 means slightly hazy, 3 means barely visible, and 4 means fundus details not visible. And by compiling the data, we have come across this conclusion that the number of cases with normal scleral thickness was 62.7%, with increased scleral thickness 11.4, less than normal scleral thickness 26%. Among the normal scleral thickness, score 1, that is the retina clearly visible, was seen in 12%, score 2 25%, score 3 33%, and fundus details was hard to see in 30%. In case of increased scleral thickness, it was 6%, 18, 35, and 41%. In less than normal scleral thickness, 23, 38, 21, and 18%. And we have also made a comparison in scleral quadrant ways. It was seen that the superior, the score 1 was in 24%, score 2 32, score 3 41, score 4 3%, temporal 15, 34, 39, and 12, and in inferior quadrant 12, 27, 34, and 27, nasal 19, 36, 38, and 7. The graph will provide a more visual analysis. That is, the scleral thickness is in the normal range. Then the retina is seen in 2 and 3 score. That is, it is either slightly hazy or barely visible. When the scleral thickness increases, the increased average scleral thickness will lead to the fundus detail not being seen clearly. And if it is less than normal average scleral thickness, the fundus details are more easily visible. The score will shift more in the 1 and 2 range. So comparing the scleral quadrants also, it was seen that in the superior scleral quadrant, the transillumination efficacy was more better. Score 1 and 2 was more seen in that quadrant, and the most difficult was with the inferior scleral quadrant. The temporal and the nasal has comparable data, and among that also the nasal has more effective transillumination compared to the temporal scleral quadrant. So we have concluded that the scleral thickness is inversely proportional to transillumination. So once scleral thickness increases, the transillumination efficacy decreases. And in the study, it was found out that the superior scleral thickness was less than nasal, less than temporal, less than inferior scleral thickness. So the limitations was also studied that the factors probably influencing transillumination that was kept untouched in the study was retinal pigment epithelial density, intraocular pressure, phakic status, and the axial length. So in OPD, we can tie an alternative for an endoluminescent. That is, we can use an insulin syringe, an LED bulb, which is connected through a wire to the battery. This is how we have made it. An LED bulb is placed inside an insulin syringe and is connected to the battery through a wire. And we have used it in this way in the OPD. So we can perform scleral indentation, and we can also get transillumination while using indirect ophthalmoscopic examination. So in a nutshell, this is the first clinical study based on LumiIndent. It was the first study comparing scleral thickness with transillumination intensity while examining retina. And in the order of best quadrant for scleral transillumination in Kerala population was found to be superior more than nasal, more than temporal, more than inferior. And pre-op assessment with OCT can be done to predict if scleral transillumination can be performed efficiently during the VR surgery. These are my references. Thank you.
First thing is that the size of the intraoperative use, that syringe cap. So sometimes one of the reasons probably you said the inferior quadrants are more difficult could be because it was not able to go as deep like you would see in the superior and temporal quadrants. Inferior quadrant usually is not very easy to go in. That could be a reason. Plus you didn't talk about how deeper or how posterior you were able to reach with this such a big device. It's not a small device. The needle size, cap size is quite big actually. That can be limiting factor. Apart from the choroidal and RP health.
Okay.
And also you said the thickness was measured 6 millimeters or 6 centimeters from the limbus.
6 millimeters.
So that may not be depictive of the scleral thickness much more posterior, because you are depressing way posterior and the measurement of the scleral thickness is so anterior, and you are trying to correlate these two, which may not be ideal thing to do.
Okay.
So in case you really want to do, you could have done an MRI to assess that will be, not cost effective, but that will be the true way of identifying the scleral thickness in the area you want to indent. Okay. So you are measuring the thickness somewhere else and trying to postpone or project that finding to some other area. And the scleral thickness may not be the same in anterior as well as in the posterior.
Okay.
So there are so many limitations of our study, and I'm not very sure about that the conclusions are valid actually. Thank you.
So we move on to the last presentation. It will be presented by Dr. Vinitha Vijayan, who will be talking on biomarkers in early response to anti-VEGF in pigment epithelial reaction diabetes.
Age-related macular degeneration is a leading cause of severe vision loss in elderly. It accounts for 8.7% of blindness worldwide. Wet AMD accounts for 10 to 15% of the AMD cases. And CNV appears to be the hallmark feature of NAMD, which can be within the retinal layers, below the retinal layers, underneath the RPE, leading to intraretinal fluid, subretinal fluid, and pigment epithelial detachment. So PEDs are composed of different materials. It could be a serous fluid, neovascular tissue, and fibrous tissue. So the fibrovascular component of the PED is the worst, indicates the worst visual prognosis. So in our study, it's a novel study where we use the pigment epithelial detachment composition indices, where the relative amounts of the fibrous, the neovascular, and the serous tissue was taken respectively, and image processing approach for discriminating the different tissues within the components of the PED was done, and changes in the fibrotic, the serous, and the neovascular components within the PED was captured by the PET-C and and this was used to reflect the anti-VEGF treatment response. So coming to the aim, it is to evaluate the pigment epithelial detachment composition in eyes with NAMD undergoing anti-VEGF therapy. It's a retrospective study and for a period of 2 years in 40 eyes of 34 patients. The inclusion criteria being the patients with confirmed PED captured on OCT at baseline, treatment naive status at baseline, 2-year follow-up with BCVA and OCT imaging, the minimum PED height being 75 microns within 3 millimeters of fovea, exclusion criteria being poor visibility of PED, drusen or PED, prior treatment and other ocular pathologies. The data parameters were the BCVA, the PED horizontal maximum diameter, the PED maximum height, PED area, CMT, the SRF area, the IRF area, the PED area, and the PET-C indices. So the images were the scans were acquired from the Edelberg Spectralis device, and we had used the ImageJ software to separate the various components: the fibrous component, the serous component, and the neovascular component. The fibrous component was a hyperreflective reflectivity. Hyperreflectivity was shown. Neovascular was an intermediate reflectivity, and serous was having a hyporeflectivity. And the fibrous PED area, the neovascular PED area, serous PED area was calculated. And coming on to the results, out of the 40 eyes of 34 patients, 70.6% of them were females and 29.4% were males, with a mean age of 75.08. The best corrected vision, as we had calculated from baseline, 3 months, 6 months, 12 months, 18 months, 24 months following the anti-VEGF therapy, showed an increment throughout the 24 months period. However, it was not statistically significant. The CMT showed a statistical change from 329 to 215 micrometers. The subretinal fluid showed a significant change from 0.13 millimeter square to 0.03 millimeter square. The PED maximal height was having a decreasing trend throughout the period, which was statistically significant. The PET-C fibrous component had an increasing trend throughout the period. The nil significant parameters being the PED horizontal maximum diameter area, the neovascular component, and the serous component. So the number of total injections that were taken were 13.38. There was an improvement in visual acuity with increase in the anti-VEGF injections throughout. The change in the PET-CF through 24 months showed a weak positive correlation with the number of anti-VEGF injections. So the PET-CF showed an increasing trend that correlated with the positive correlation because there was a BCVA improvement, and the neovascular and the serous component had nil significance. So PET-C may be used for prognosticating and treatment management. PET-CF had an increase as the proportion of the PED space became less composed of the serous and the neovascular tissue, which was reflected by the decrease in the PET-CS and the N component. So this case supports the PET-C's use as a predictive biomarker for fluid recurrences. Coming on to the studies, Jawahari et al. Found that the anti-VEGF therapy in treatment-naive patients led to flattening of PED, but had no correlation with the visual outcomes. Smid et al. Also had, they showed the presence of PED had a minimal impact on the visual acuity. In our study, the reduction of PED corresponded to the increase in the PET-CF indices, resulting in a better visual acuity. In other study by Smid and Forth et al. Evaluated the PED area, location, volume, had no correlation with visual acuity. Ching et al. Looked at the PED morphology, including the height, width, volume. They had no correlation with the visual acuity. However, in our study, the PED area was reduced following administration of anti-VEGF therapy over the period of 24 months, but was not statistically significant. So many of the patients had persistence of disease activity even after improvement of the treatment. There was an increase in the PET-CN and decrease in the PET-CF at 6 months interval, and continued anti-VEGF injections in patients likely led to the resolution of the serous fluid, corresponding to stabilization of the PET-CS after 12 months. So this postulates that the role of PET-C as a clinical predictor for visual outcomes and disease activity. So in a nutshell, the positive biomarkers for good response following anti-VEGF were the increase in the PET-CF, the decrease in the PED maximal height, reduction in the CMT, reduction in the SRF area, and the negative biomarkers were the increase in the PET-CS and the PET-C, increase in the PET-CN. So this study provides a longitudinal analysis of the novel OCT imaging biomarkers generated through the automated image modalities quantifying the fibrous, neovascular, and serous components. So PET-C has a role as a biomarker for visual outcomes and disease activity. Quantification and characterization of the tissues within the PED provides an additional matrices for clinicians to assess treatment response and aid in appropriate management. Limitations were the quality and the variability of images, and the image processing algorithm used extracts intensity informations on per pixel basis, thus making this a microscopic structures difficult to capture on OCT. The presence of differences in the image quality and resolution between OCT devices was also one of the limitations. Thank you for the kind attention.
What was this algorithm which you were talking about? Is that the automated algorithm?
So we use the ImageJ software,
Okay.
and we calculated the PED indices based on the ImageJ software. So we had set in the patients with hyporeflective as the fibrous component, hyporeflective as a serous component, and intermediate was the neovascular component.
This was a custom-made software.
Yes.
Using which
ImageJ software.
image?
J.
Okay, J. Okay. So then, did you include all the anti-VEGF, or you're focusing on one particular anti-VEGF?
Yeah, we included all the anti-VEGFs.
Okay. So the machine, how good it was to differentiate? You gave that this is a fluid and this is a
Yeah,
tissue.
we had instituted that into the machine, and based on that, they had calculated the parameters.
Okay. So when you're trying to work with you clubbed all the anti-VEGF into a single group and studied the response.
Yes.
Which may not be a valid thing, because we know that some anti-VEGF have a better response in the sub-RB component. So that may be a little bit skew or findings, because some of like brolucizumab as well as aflibercept and Vabysmo, probably they have a better effect on the sub-RP component compared to routine Avastin and Lucentis. So that may a little bit give you a skew in your findings. That you might be aware of that.
So we are doing a
But you didn't show any image like for using that algo. Can you show that again? You have any algo?
No, I don't have that image.
So that is very important. Now, if you want to get an idea of how you are reading, whether the image was being read correctly, whether the fluid component, the neovascular, all those things, whether the image is automated software is reading correctly. So we need to get an idea of whether the machine is able to. You should have showed that, so that we get a more confidence in your robustness of the data.
And I just have a very naive question. So, when you know that there can be multiple components in pigment epithelial attachments, how do you qualify all these biomarkers which has been viewed individually for positive and negative trends?
So I didn't get your question. Yes.
Correct.
Okay.
So each eye and each
So
PD,
based on
sometimes
the amount of which component is greater, based on that we are taking it.
no, not that. So there are multiple components in each of these PEDs, right? So one which is based on the software which you have been evaluated. Now, how do you come to this conclusion of positive and biomarkers and the negative biomarkers when you have various components in each PEDs?
So I had actually checked the amount of the, so if the fibrous was higher, probably that is good response to treatment. Was what?
What the data, you're not confident that everything has happened. Sometimes this combination of everything. Independently, how you have showed some pictures to show like pictures of how the software read about each component. We'll have more confident data in the system. So you just put numbers, and the way you assess this is not open, not like routine image software which is available for everybody, so you know what you're talking about. You're presenting something new, and we're not aware of that, so it doesn't give us confidence on the data you're